Welcome to our comprehensive guide on arterial blood gas, or ABG analysis. This fascinating subject offers a window into the intricate workings of the human body. In this video, we'll untangle the complexities of ABG calculations, explore the mechanisms of compensation, and walk through a series of practical examples. Our goal? To help you master ABG interpretation, a critical skill in healthcare. ABGs provide valuable insights into a patient's respiratory and metabolic status by measuring the levels of oxygen, carbon dioxide, and pH in arterial blood. Let's begin by understanding the significance of ABGs. Arterial blood gas analysis, or ABGs, serve as a window into a patient's respiratory and metabolic state. They allow healthcare professionals to measure crucial factors in the blood, including the levels of oxygen and carbon dioxide, as well as the pH. This information is indispensable when it comes to assessing a patient's lung function. But that's not all. ABGs also help us evaluate the body's acid-base balance and overall oxygenation status. Think of them as a comprehensive health report, providing a snapshot of how effectively a patient's lungs and kidneys are working together to maintain the right balance of oxygen, carbon dioxide, and pH in the body. So, whether it's diagnosing a respiratory disease or monitoring a chronic condition, ABGs are a critical tool in the medical toolkit, vital for assessing lung function, acid-base balance, and overall oxygenation status. Before we dive into calculations, let's familiarize ourselves with the components of ABGs. There are 5 key components we need to be aware of: pH, partial pressure of oxygen, or PaO2, partial pressure of carbon dioxide, or PaCO2, bicarbonate, which we'll refer to as HCO3, and oxygen saturation, or SaO2. Now let's break these down. First up, we have the pH. This tells us the acidity or alkalinity of the blood. A normal pH range is between 7.35 and 7.45. Anything below this range indicates acidemia, while anything above suggests alkalemia. Next, we have PaO2. This measures the amount of oxygen dissolved in the blood. The normal range for PaO2 is between 75 and 100 millimeters of mercury. If PaO2 levels are below this range, it signifies hypoxemia. Moving on to PaCO2, which measures the amount of carbon dioxide dissolved in the blood. The normal range for PaCO2 is between 35 and 45 millimeters of mercury. A higher than normal PaCO2 indicates hypercapnia, while a lower than normal PaCO2 suggests hypocapnia. Our fourth component is HCO3, or bicarbonate. This is an important buffer that helps to maintain the pH of the blood. Normal bicarbonate levels range from 22 to 26 milliequivalents per liter. Levels outside this range can indicate either metabolic acidosis or metabolic alkalosis. Finally, we have SaO2, or oxygen saturation. This measures the percentage of hemoglobin that's carrying oxygen. The normal range for SaO2 is between 94 and 100%. Each of these components plays a crucial role in determining the acid-base status and oxygenation level of the blood. By understanding these components and their normal ranges, we're setting the foundation for effective ABG analysis. But remember, each patient is unique, and these values can vary based on individual circumstances. So always consider the broader clinical picture when interpreting ABGs. And that wraps up our discussion on the components of ABGs. Each component plays a crucial role in determining the acid-base status and oxygenation level of the blood. Now, let's learn how to calculate ABGs in a stepwise manner. The beauty of this approach lies in its simplicity and systematic nature. You'll find it's like solving a puzzle, with each step bringing you closer to the big picture. First, we start with assessing the pH. The pH of the blood gives us a quick snapshot of the acid-base status. It tells us whether the blood is acidic, basic, or within the normal range. The normal range for pH is between 7.35 and 7.45. If the pH is less than 7.35, it indicates acidemia. If it's above 7.45, it signifies alkalemia. Once we've determined the pH, the next step is to examine the partial pressure of carbon dioxide, or PaCO2. This component helps us understand the respiratory contribution to the acid-base status. A high PaCO2 suggests respiratory acidosis, while a low PaCO2 points to respiratory alkalosis. Following the PaCO2, we turn our attention to the bicarbonate level, or HCO3. This gives us insight into the metabolic component of the acid-base balance. A high HCO3 indicates metabolic alkalosis, whereas a low HCO3 suggests metabolic acidosis. So, in essence, the stepwise approach involves 3 key steps: assessing the pH, analyzing the PaCO2, and evaluating the HCO3. By following this sequence, we can identify whether the primary disturbance is metabolic or respiratory, and if it's acidosis or alkalosis. Remember, practice makes perfect. The more you apply this stepwise approach, the more intuitive it becomes. Soon, you'll be able to glance at an ABG report and instantly grasp the acid-base status of the patient. Next, we'll analyze PaCO2 and HCO3 levels to identify respiratory and metabolic components of acid-base disturbances, respectively. This will take us one step further in our quest to master the art of interpreting ABGs. Understanding compensation is key to interpreting ABGs accurately. As we dive deeper into this topic, let's remember that our bodies are a marvel of balance and adaptation. When it comes to maintaining the delicate acid-base equilibrium in our blood, 2 main players come into action: our lungs and our kidneys. These organs are the heroes behind the scenes, working tirelessly to keep us healthy and functioning. Now, imagine a scenario where the blood becomes too acidic due to an excess of carbon dioxide. This is where our lungs step into the spotlight, increasing the rate and depth of breathing to blow off the extra carbon dioxide, a process we refer to as respiratory compensation. On the other hand, let's consider a situation where the blood becomes too alkaline due to a deficit of carbon dioxide. In this case, our lungs would decrease the breathing rate, conserving carbon dioxide to bring the pH back to normal. But what if the disturbance is not respiratory, but metabolic, like in the case of excessive bicarbonate? That's when our kidneys come into play. They can either retain or excrete bicarbonate, adjusting the blood pH over a period of hours to days. This slower, yet equally essential process is known as metabolic compensation. But here's the catch: compensation is not always a perfect fix. Sometimes the body's compensatory mechanisms might only partially correct the primary disturbance, leading to a state of partial compensation. At other times, the body might fully correct the disturbance, leading to a state of full compensation. So, when interpreting ABGs, it's not just about identifying the primary disturbance, it's also about understanding how the body is trying to compensate for that disturbance. Is it the lungs or the kidneys that are stepping in? Are they managing to fully correct the disturbance, or is it only a partial fix? Compensation may be partial or full, depending on whether the compensatory mechanism adequately corrects the primary disturbance. Understanding this can help us in not only interpreting ABGs accurately, but also in identifying the underlying cause and guiding appropriate treatment strategies. Let's put our knowledge into practice with some examples. Imagine we're presented with a case of a patient exhibiting signs of shallow, rapid breathing, and their ABG results show a high pH, low PaCO2, and normal HCO3. This aligns with a condition called respiratory alkalosis. The high pH indicates alkalinity, and the low PaCO2 points to a respiratory cause. As the HCO3 is normal, this suggests there's no metabolic compensation happening. Now consider a different scenario where a patient is experiencing deep, slow breathing. Their ABG results reveal a low pH, high PaCO2, and high HCO3. This is indicative of respiratory acidosis, with a compensatory metabolic alkalosis. The low pH shows acidity, and the high PaCO2 suggests a respiratory issue. Let's look at another example. In this case, the patient has been experiencing prolonged vomiting. The ABG results show a high pH, low PaCO2, and high HCO3. This is a case of metabolic alkalosis. The high pH indicates alkalinity, and the high HCO3 points to a metabolic cause. Finally, consider a patient with severe diarrhea. Their ABG results reveal a low pH, high PaCO2, and low HCO3. This is indicative of metabolic acidosis. The low pH shows acidity, and the low HCO3 suggests a metabolic cause. The elevated PaCO2 indicates that the respiratory system is compensating by retaining carbon dioxide, thereby raising the pH. By applying the stepwise approach and understanding compensation, we can accurately interpret ABGs and identify underlying respiratory and metabolic disorders. In conclusion, mastering the calculation of ABGs and understanding compensation mechanisms are essential skills for healthcare professionals. These tools offer invaluable insights into a patient's respiratory and metabolic status, aiding in the diagnosis and management of various disorders. With a systematic approach to ABG analysis, you can unravel complex clinical scenarios and make informed decisions. And remember, practice makes perfect. By following a systematic approach and practicing with practical examples, you can confidently interpret ABGs and provide optimal patient care.